First of all, I would like to say Assalamu alaikum and good evening to all my dear friends and colleagues. I would like to thank our here eminent speaker with us, Dr. Danish Tilwar, Dr. Maya, and Dr. Nazim. And I want to apologize for Dr. Ayman Midanat. He was supposed to be with us, but unfortunately he became sick, and he was till the last minute trying maybe to be with us. We will wait and see, but I think he is sick, and he sent already his presentation, but actually we check it is a very nice and excellent, and we don't want just to present it like this. We want him to present. He will give it better than us. Other things that I would like to thank also our sponsor today, Alimera, for sponsoring our meetings. To thank our support teams here from MarVision for being with us in MIOM. And I would like also to thank all our attendees and participants. They are going to be with us today, and we are having to talk about information about the quick, so many questions and many people they are sending when it will be the certificate. The certificate is prepared by Training and Development Center of Mohab. So that's why it takes a little bit time. But as we mentioned earlier in the beginning of the conference, it will be about 6 weeks after the conference. And we are having 2 weeks more. So we hope in these 2 weeks, we can finish it. Without any further ado and late, I would like first to introduce our first speakers today. Dr. Maya Bandova, a consultant of ophthalmology. She is in a Kuwait oil company, graduated Medical University, Varna, Bulgaria, and she's an ophthalmology board Medical Academy, Sofia, Bulgaria, worked in Kuwait since 1995. Dr. Maya, she will give a talk about early result with Iluvien insert. Dr. Maya, is the mic with you, please.
Thank you so much. Dear colleagues, it is such an honor to be invited to present my early data on Iluvien in such distinguished audience. My slide opening nicely?
Yes.
Great. Clinicians my generation will remember what enthusiasm we felt when we started giving intravitreal anti-VEGF injections. Particularly for us in the Middle East, diabetic macular edema is such a huge problem that we were looking for solution from the onset of clinical practice here. As soon as we started, we noted substantial number of people did not improve after intravitreal injections, and these results were actually confirmed later on with the protocol T results, because even in their well-controlled diabetic patients with vigorous injection treatment, all three anti-VEGF molecules did not provide substantial improvement in more than 40–60% of the patients. And even though they continued treatment, they would not obtain better response. Moreover, that it was followed by decrease of vision and loss of vision even. What is even more important, those people who would not improve after the 3rd month, they would not improve even further on up to 26 months. So this first initial period was telltale. What to do for these people? We need to look for another solution, and it came with this elegant little cylinder with a very particular membrane closing on each side, containing fluoroquinolone acetonide for intravitreal implantation, fairly nice and elegant, much smaller than the Retisert that we used to know before, easy for injection through pars plana. That membrane maintains therapeutic concentration in the vitreous for approximately 24 to 36 months post-injection. And the lower dose seems to be good enough for treating patients. A series of studies were undertaken to obtain the approval of the FDA, and it came out that actually the patients do improve structurally. The mean foveal thickness did decrease, and it was associated with substantial improvement in the patients both with duration of macular edema for more than 3 years and less than 3 years. However, there were side effects as well. There was a large percentage of patients with cataracts if they were phakic, and there was increase in the IOP that requires a surgery for some of the patients. Actually, this is not that much new. If we look at what we saw with dexamethasone implants, we saw exactly the same drop in the vision around the 18 months that was associated with the cataract formation in the phakic patients. And pseudophakic patients and patients that had cataract surgery after that actually had substantial improvement in the vision. However, typically for Ozurdex, we see this fluctuation in the structure and in the vision as well. FAME was one of the pivotal studies, and that demonstrated quite the same. Cataract surgery done after the implant actually improved the patient's vision to a level similar to that in the pseudophakic patients prior to implantation. What is even more important, and to a topic that we'll listen later on today, some of the substantial group of the patients had improvements in their severity of PDR. Even more, that progression of retinopathy and regression of macular edema was observed in a quite substantial percentage over time. Several real-life studies demonstrated actually that the number of people who need Iluvien vary according to the previous treatment. And after the Iluvien, 63% in that particular US study did not require any further treatment. Now, this is the important point. Those patients who started with high visual acuity, they benefited best. They had the highest visual acuity. But even those who had poor visual acuity, they did improve and they gained most. The intraocular pressure in the real study, life studies actually was not that much elevated compared to FAME. And actually none of these patients needed surgery for glaucoma. In November last year, Drs. Jaffe and Carlos Pavesio published this interesting work that was a prospective assessment of intravitreal Iluvien treatment for patients with non-infectious uveitis. It was a multi-center trial and it involved a very substantial number of patients. Now, what is important? The stability of the patients. The days to uveitis recurrence increased significantly in the first graph. That is sham and that is the post-Iluvien. On top of that, the systemic treatment that those people needed was substantially less compared to patients on sham. What is even more important, the visual acuity in the patients with the implant was significantly higher. And the subfield, the structural changes in the macula, was significant and sustained. What is even more important, in their findings, the pressure of the patient did not increase to levels requiring surgery. And the cataract surgery was, again, in the 73 to 23% compared to the control group. So basically, our distinguished colleagues are recommending Iluvien for this particular group of uveitis patients. Okay, that is for their patients. We keep asking, what about our cases here in the Middle East? Let us look at this 85-year-old lady, non-diabetic, pseudophakic, PDR, PRP was done. However, the patient keeps coming with severe macrocystic macular edema. For 10 years, as you see, we tried quite a lot of things. She was on aflibercept, ranibizumab, and dexamethasone with improvement, however, a bit unstable. And she keeps coming with vision that fluctuates around 20/40. And she never had pressure problems. This is a typical episode. You see the inflammatory reaction in the macula that is increasing and decreasing with Ozurdex and Lucentis. Finally, November last year, 2019, I gave her Iluvien in her right eye. You see the nice regression, although incomplete, and the vision of the patient 2030. The pressure was fairly nice. And then pandemic. The patient had ischemic heart disease, catheterization, and deteriorated metabolic control. In September, she was also infected with COVID and she needed admission. During all these events, her macular edema was quite unstable. However, for these 17 months, I needed to give her only 2 Lucentis injections. The last picture here I took for you. She came to my clinic yesterday with 20/25 vision. Her pressure was 11. I was quite satisfied with the good vision. That is after the second Lucentis injection. Now, I wanted to show you these. Despite all these fluctuations in the macular edema, despite the severe systemic complications and clear ischemic heart disease, we were able to retain the microcirculation of the patient and the structure of her ellipsoid layer. Now, this is another person, 66-year-old gentleman with type 2, pseudophakic glaucoma, well controlled on COSAP, horrible recurrent macrocystic macular edema. He had regular ranibizumab and aflibercept injections. However, typically for the Middle Eastern patient, he decided to try his chances in Paris. And there he developed aseptic vitritis after aflibercept. He came back to Kuwait with recurrent edema. I gave him ranibizumab and he had again aseptic vitritis. Obviously, quite a risky person from every point of view. His treatment was interrupted from November 19 to April 20 during the lockdown. And then he came with this horror, and this is one typical episode in 2018. And then after the aseptic vitritis, he kept coming with severe recurrent exudative macular edema. However, very nice vision, 20/20 with reasonable pressure on COSAP preservative-free. And then after all this turmoil, in April last year, he came with this huge exudative edema. You can see the first graph is January to April last year. And then I gave him Lucentis. He had very mild, I can say negligible response, and then Iluvien. He tolerated the treatment well, and his pressure was fairly nice. However, during the whole this period, almost 1 year, he had all sorts of metabolic issues. They kept changing his diabetic treatment. He had early renal failure. Besides, his father passed away. He was under great stress and hypertensive reaction. He kept coming with recurrent increase and regression of his macular edema. I offered him several times Lucentis. However, he said, I'm improving spontaneously. Let me try my chances. If I will not improve spontaneously, then give me what you want to give. So this is his last OCT in the rightmost side, and you will see that his macular edema came back again. However, his vision is in the range of 20/25/20/30, his pressure well controlled, and for the time being, the patient himself doesn't feel compelled to have further treatment for this eye. That is his microperimetry. As you see, he has substantial decrease in his inferonasal quadrant of the macula. The whole area here is shifting towards less sensitivity. However, for a person with this severe macular edema for all these years, we can say his vascular function is not that bad. And now this is central vein occlusion. It's off-label. However, these are difficult eyes that are not responding to treatment. Treatment was offered, patients accepted, and we went ahead with Iluvien. This is a 25-year-old lawyer with mild arterial hypertension. He presented to me more than 12 years ago with severe macular edema and ischemic type of CRVO. Practically all my treatment was useless to control the macular edema for more than a month and a half. Panretinal photocoagulation was done, Ozurdex given, cataract surgery done, vision is hovering between 2050 and 2025, and his pressure is elevating under Ozurdex. However, he's responding to Combigan. A typical episode is this 2018 period of time when he responds very well to Ozurdex, and then the edema comes again. So finally, after one severe recurrence in April last year, the patient said, give me something that will be lasting longer, and see how nicely he dried out. Vision improved, pressure was 24, however, he was given a Combigan and he responded very well. Now this is what happens for the last few months. Macular edema is stable, vision is stable, pressure is responding very well. And that is his photography and microperimetry. These are very damaged posterior poles. You see the inferonasal quadrant of the patient is more or less retained, but the superotemporal is having less sensitivity. You see the scatter of his fixation, the blue dots? It is not central, it is extracentral and very unstable. On the other hand, we have a 57-year-old female physician who presented with semicentral vein occlusion and severe macrocystic edema. She had ranibizumab, aflibercept, dexamethasone, cataract surgery done, and very unstable macular edema. This is a typical period. You see the increase and regression of the edema under treatment. She responds beautifully, however, very unstable. In 2019, after a series of intravitreal injections, we decided to go ahead, and in November, I gave her Iluvien. See the nice drying of the macula, pressure 11. We succeeded in retaining circulation in the superficial layer in the left lower corner, and the patient was very nice and stable for 1 year until November 2020 when she came with a recurrence. It was bothering her, the vision was decreasing, so I gave her Lucentis. She improved until February this year when she presented with recurrence, second Lucentis. She responds very well with 20/20 vision. So for the time being, after 17 months, I needed to give her only 2 Lucentis injections. As you see in that superotemporal quadrant, the sensitivity of the patient is significantly less. However, she is functional, she can read, and she can manage with her computer work as it is. Central fixation, which tells me that most probably the perimacular area is still retained. Now, this is one typical story. This 85-year-old gentleman is a senior in his tribe, and half of the tribe is in Kuwait, the other half in Saudi Arabia. He is literally butterflying between us and the Saudi colleagues. He had vitrectomy combined with vacuum emulsification, membrane peeling from vitreomacular retraction syndrome, and relentless uveitis that was causing him recurrent macular edema, pain, and photophobia in the eye. He had injections. I know what I gave. I don't know what they gave, but he did not improve significantly, and his vision was in the range of 20/40/20/70. Last year, he came with a very severe inflammatory response in his eye. This is the typical response to topical treatment and then Eylea injections. In 2019, again, butterflying here and there. And then Iluvien. If you look at the OCT, nothing much. However, the vision of the patient improved significantly, and he did not have a single inflammatory recurrence since the September Iluvien in his eye. His pressure remained in a normal range, so practically he is not using anti-glaucoma drops. That is his photography with improvement in the clarity in the vitreous after the Iluvien injection. And now this is one big headache, a 65-year-old diabetic lady with bronchial asthma, non-pulmonary tuberculosis, bilateral panuveitis. She had PDR treatment. Her right eye underwent phacovitrectomy, and actually the right eye was always the stronger one. She had mild complications after the surgery. However, her vision was 20/50 in the right and 20/150 in the left. Recurrent anterior and posterior reactions. She responded very well to Ozurdex. However, she was very unstable. So finally, I decided to give her Iluvien in the left eye. She was my first patient. I had to be very cautious so that even if I will have complications, I will not have much to lose. She improved very well, and I was so happy. And then she disappeared again. Last year, during the lockdown, she developed very serious pulmonary problems. She was admitted, and our colleagues were busy saving her life, so they realized her vision came down only after she was able to speak at all. And then the good eye was having 2400, and she was having severe anterior and posterior recurrence of the uveitis. The left eye, however, with the implant, had no cells of flare and no reaction in the vitreous at all. We needed to give her a bit of topical treatment, and she improved. Now this is the left eye with the Iluvien. As you see, nice and stable, despite that spike of severe problems, metabolic and pulmonary. And that is the right eye. You see, it was nice and beautiful, very clear. And only 2 months later, now this is not artifact, colleagues. This is the vitreous haze and the anterior chamber reaction that is causing the haziness of that view. So to summarize, for the first year, my diabetic patients responded well. They had sustained regression of their edema. In those patients who had early intensive pre-Iluvien treatment, the visual acuity was high. There was no deterioration of retinopathy severity. We succeeded in retaining the microcirculation in the macula. However, there were fluctuations in the edema. The patients need close monitoring, occasional intravitreal injection, actually no glaucoma, and those patients who had previous IOP spikes responded well to their previous treatment. To me, PRP, or focal laser, and management of the ischemic component of the retinopathy is key to successful management of these patients. The uveitis patients were actually responding pretty well for this 1 year. However, we kept in mind the possibility of recurrence. The presence of pseudophakia is the key. It was cost effective because my patients needed 5 to 6 visits annually, and so far I did not need to top up the treatment. And the vein occlusion patients. Now these are difficult eyes, however, we succeeded in controlling the edema. In those patients who had early intensive previous treatment, the vision is high. There is, however, persistent hypoperfusion in collaterals. The elevation was only in 1 eye with a previous steroidal responder. There is substantial fluctuation in the edema, so these people need close monitoring, and there is always the possibility of topping up with the VEGF, and again, laser management is a must. Many thanks.
Thank you very much, Dr. Maya, for this comprehensive and excellent presentation. actually you show us all the different or the clinical situation that you treat, uveitis to macular edema, CRVO, and all. So it's very nice and excellent. We will have maybe many questions. We'll start Dr. Nadeem or Dr. Danish if you have any question to Dr. Maya.
Yeah, I have one very simple question. Wonderful presentations of different variety of patients you have shown. So what is your algorithm or treatment of patients with macular edema secondary to retinal vein occlusion? Okay. So it looks like you start with anti-VEGF, then you go to Ozurdex, then you use fluocinolone acetonide. So when you use anti-VEGF, what is the treatment protocol you follow until you reach, and what is your criteria to use steroid implant?
The first 6 months are the key. And it seems that we need to start with the laser treatment together with the anti-VEGF. Actually, this is very supportive. Once we decrease the edema with the anti-VEGF, our laser treatment seems to be much easier and more effective. 3, 4, tops 5 intravitreal anti-VEGFs will tell us if the patient is responding and if he is stable. If the patient is unstable, even in a good responder, the patient will complain of vision that will be non-functional. So this is the time when we discuss the possibility to start the Ozurdex treatment. In aphakic patients, we discuss the possibility of cataract. After the first or second Ozurdex, mostly they do not develop cataract. However, in the long term, it comes. Same goes for the IOP spikes. In the end, if the patient will stabilize systemically, 2 or 3 Ozurdex injections per year are mostly enough to maintain very good function. However, in elderly patients, in patients with advanced systemic disease, particularly if it is combined diabetes and hypertension, mostly they are very unstable and the vision fluctuates a lot. And it does not come back to the initial level after the Ozurdex treatment. For these patients, and particularly during the COVID period, Iluvien turned out to be a very useful solution. Only those people, however, who responded successfully to Ozurdex, they may benefit from the fluocinolone. If the patient did not decrease the edema with the Ozurdex, it's pointless to expose to Iluvien injections.
Dr. Maya, I had a question for you. From your presentation, it seems that increased intraocular pressure, you did not find as much of a problem with Iluvien. If that is so, then why didn't you go straight away? Why did you shift to Ozurdex first? Why not go straight from anti-VEGF agents to Iluvien?
First of all, historically, Iluvien came in the market only in 2019. Many of these people got the Ozurdex long before that. So I need to see if patients are responding to steroid. There are several patients in my clinic that including steroid. So for those people, it is pointless to give fluocinolone that will stay there for 2-3 years, and that may cause a lot of other complications without visual benefit. Even now, if I have a treatment-naive patient, I will start with the anti-VEGF. It's light, it's gentle, it's helping me with the retinal condition. However, if that edema is recurrent, I will try the Ozurdex, and I'm actually monitoring the outcome with OCT and vision weekly to see if that edema is responding. And same goes for very severe diabetic macular edema, by the way. And if that patient will respond favorably to Ozurdex, then there is a point to give him Iluvien. Otherwise, it's pointless.
So what are the serious problems you've seen with Iluvien?
It's ridiculous. That slippery thing is actually not stuck to the cannula. So the most unpleasant thing that happened to me is that while preparing to inject the implant, it slipped out of the cannula. So now, and by the grace of God, it did not fall on the floor. So I keep now the syringe nicely up with the cap, and then once I'm over the injection site, I will remove the cap and quickly do the implantation. However, we keep watching them for endophthalmitis. We keep watching for some retinal complications, bleeding. Most of these eyes had already PRP, so I'm not afraid of retinal detachments. However, I keep watching for structural things that may get worse with the steroidal implant. It is much more gentle compared to the Retisert. And we don't see those bad surgical complications that we used to see with the Retisert before. It might be lighter. It might have lower therapeutic concentration. However, if you top up from time to time with this and that, mostly you can maintain them in pretty good shape. It's like tailoring.
Mohammed,
Yes.
did you face the same problem? You have given a lot.
Which problem you mean? Yes.
That the implant fell down.
No.
So how do you give? Do you remove the cap just before you inject and keep it
actually, this
vertically?
For Iluvien, it is two processes. You have first of all to push the Iluvien from the place to prepare for injection. Just it will be seen, there is an area you can see the Iluvien. Then you have to push it forward. Then after that, it is a different maneuvers. It should be like press down and move forward. The second step, then you have to do the injection. Then you will press it from the back. Then it will be easily slip inside the eye. So it is two step. That's why there is no problem. Only one times it's the patient move while I'm doing the second step, so it become out. But easily I take it and put it in same side of the needle itself and re-push again, and it was nicely pushed inside the eye. Only happened one time with me, but because of the patient. But usually I'm trying to be sure that when I don't do or I remove my hands, I keep the eye, put the needle inside the eye, then press it. So to avoid these complications or to avoid the falling down of the insert outside.
Yeah, there are a few questions, Mohammed, on the chat.
Yeah, there is one most important question here. I think this one, how do we know if the patient is a steroid responder before Iluvien injection? This can be for you, Dr. Banda, or it could be for anyone to comment about that.
Maya, can you?
Yeah, Dr. Maya, please. Yeah.
Most of the time we know. If the patient underwent previous procedure and was treated on prednisolone, for example, we know that he was prone to develop elevated pressure. If we follow what European colleagues are recommending and give an Ozurdex implant before that, they will be able to see the spike in the pressure for sure. And they will see the response to topical treatment. Generally, this approach is very common sense. Moreover, that after 2-3 months, the Ozurdex will resolve. And even if there is a spike in the pressure, you will be able to see if the problem is serious enough so that you will not give the Iluvien implant. I was expecting to see much more spikes in the pressure. However, our patient responded very well. So far, thanks God, I don't have glaucoma surgery. And I don't have significant problems with optic disc cupping.
Okay, is there any comment from Danish or Dr.? Yes, Dr. Go ahead, Dr. Nazim.
No. The same question. So I wanted to ask Dinesh, how do you judge a steroid responder rather?
So I actually put my patients on topical steroids at least 4 times a day for 4 to 6 weeks. during the time when they are on anti-VEGF agents.
Which one do you use as a, which steroid do you use? Do you use
Usually we are using
dexamethasone?
prednisolone. Prednisolone acetate is the usual form being used.
1%.
1%, yes.
Okay,
So,
for how long, Dr. Danish, for how long?
I actually use it for 4 to 6 weeks. You see, what I do is I use this as a sort of a treatment for the cystoid macular edema component anyway. So I let the treatment continue topically in addition to whatever anti-VEGF agents I've been giving. So I know if the pressure has gone up, then I will be a little careful. And if the pressure goes up, then I see that it should not need more than one drug. If it needs more than one drug for control, then I will not put the patient on Ozurdex. We don't have Iluvien, but I don't give Ozurdex also in these patients.
Okay. Actually, for me, Dr. Nazim, Dr. Danish, I usually before, not now these days, if the patient is naive and we are going to use for a steroid and we don't know about him, I give only even for 1 or 2 weeks, but a high dose, 8 times per day, and for Bradford, and we will see. Because this one, they are going to have, if they are really a steroid responder, they will show immediately. It will not take that long.
Sometimes these are duration dependent.
Yeah.
If you give it for long enough, they will develop it. In a short duration, they will not develop it. So that is why I prefer to let them be on steroids for some time. I get an idea whether these patients are going to go up. If the pressure doesn't go up, the edema will go down. So either way, I gain.
It's another, yes, another way. Sometimes, do you think we need to give for this one for Dr. Amaya or Dr. Danish and Dr. Nazim to give an Ozurdex before moving to Iluvien? You know, it's sometimes the dose of Iluvien is less than the dose of Ozurdex, and the possibility of high an intraocular pressure. If we think about the dose itself, it will relate it to the dose. It will be very less in Iluvien. So, what is your opinion about this one to move directly from anti-VEGF to Iluvien direct? Dr. Nazim, because Dr. Danish, he is not using Iluvien, so
yes. So
no,
that's what I was asking Dr. Maya, whether you know, why not go straight to Iluvien?
Actually, if you consider the two different molecules, the spikes in the pressure, particularly with fluocinolone, are supposed to be slightly less compared to dexamethasone, for example. And even I was attending recently a lecture of Professor Laurent Kojikian. I think Dr. Mohammed, you will remember, he was giving excellent talk to us previously on that same meeting. Now, Professor Kojikian is giving implants, 2 implants at once. He's giving Ozurdex and Iluvien. He wants a good kick in with the Ozurdex to shut down any inflammation at the back of the eye, and then maintain this outcome with the long-lasting Iluvien. However, in our patients, I don't see that much of need for such aggressive behavior. And one thing that we keep losing out of our field of vision, most of this is related to a systemic disease. And the worsening of the systemic disease is worsening the edema. Most of the time, if we control issues, the inflammatory issues, the blood pressure problems, the ischemic heart disease, these people will improve very nicely with less treatment and less complications.
Do you have any experience, Dr. Maya, to give a naive patient Iluvien? Did you have any?
No. All my patients are pseudophakic. All my patients had previous treatment.
Yeah, I mean pseudophakic, but he was not treated with anti-VEGF. Treated.
Yes. Anti-VEGF, Ozurdex, the full range. That is for the time being my last option.
Okay, there is actually 2 way of giving or for the Iluvien. I think there is an European and there is an United States. To give steroid or not mandatory to give steroid like Ozurdex. European, they don't give Ozurdex. They go directly after the anti-VEGF And some doctors, they are start also having treating the patient with macular edema, diabetic macular edema with Iluvien as a naive patient. And I have some patients, also a naive patient, by the way, about giving directly without starting with any anti-VEGF. Is there any other questions or comment before we move to our next speakers, Dr. Nabil?
I'm not very sure of using such a long-term like fluocinolone acetonide implant in a treatment-naive patients. So I have a reason, because you will not know that whether these patients with any other treatment other than this long-term implant may respond with few treatment itself, than putting something which you can keep it for 2 to 3 years. So having said that, yes, Ozurdex or the Dex implant is very short acting, rather 3 months. So you can propose to even use as a treatment naive patients, because you know it won't, you may overtreat it. So because you may see in your experience, when you are giving PRN treatment for patients with macular edema, you will see a patients vary a lot. And that is why you judge your patient how long you are going to put any intravitreal injections, and each patients are different. Especially in case of macular edema secondary to retinal vein occlusion or diabetes. I'm not talking AMD. So I think fluocinolone acetonide needs to be justified for treatment naive.
You are asking
I don't believe steroids are the drug of first choice, because you don't know which of your patients are going to be the good responders. So I would suggest that you should see patients with three intravitreal anti-VEGF injections. Those who respond well, that means who show, say, 10-letter improvement or close to 10-letter improvement, those should not be considered for other treatments. They will respond very well to anti-VEGF treatment. Those who do not show any significant improvement within the first 3 injections, those are the patients whom one should consider for shifting to steroids. And I would say you have a choice. If you think Iluvien is safer than Ozurdex, you could consider Iluvien in these cases. But if you think that Ozurdex is safer, then Ozurdex is the way to go.
Usually, actually, Dr. Danish, it is sometimes the situation of the patient is putting you in a way that you will start him either in this drug or that. During the COVID period, you will feel that if you give a steroid better than you cannot bring the patient every month and one-time injection. The other one is to do OCT and follow up, then to give another appointment for another injection. It is very difficult. Sometimes they are very old, they don't want to come even at all. Sometimes they are from far away. There is many situations that they force you to go and to think about another solutions. And this kind of patient, I know it's sometimes you feel how it will work, how it will follow, but we are following the patient in one way or another just to control the most important complications, especially if the patient is, for example, is a pseudophakic. So the only thing to worry about if there is an increase in intraocular pressure or not. That's maybe the only things. But if you feel that the patient is not in a history of increased intraocular pressure, you give him a certain period of time of drops and there is not responder, there could be an increase, but not that much. And you can just treat it with one or single or double drops of anti-glaucoma. That's the reason sometimes you are forced to go for this certain way to give us a naive patient, either Ozurdex or Iluvien.
Dr. Amri, you know what I believe? I think when you counsel your patient, you tell him this is the protocol based on scientific medicine. This is evidence-based medicine. I will go taking the most safe approach for you. However, now you have to tell me if you're not going to be coming back for regular follow-ups, then this is the alternative I can suggest to you. This is not as safe as the standard of care, but this is the next alternative. So that way, the patient has the choice of making the effort. We are not making the decision for the patient. The patient
No,
must
sure,
make that
sure.
decision.
This one is no doubt about this one, because this one, it will be a discussion with the patient and the family.
Yes.
And we are having something that
Sure,
consent
so-
they have to sign about all this information should be explained very well to the patient. I'm
Yes.
talking about in general, about the
Yes.
general situation.
I agree with that.
Yeah, Mohammed, I think we should go ahead.
Yes, I think the time we already have around 1 hour. We are talking about this one. Thanks a lot, Dr. Maya, for this an excellent presentation.
Yes.
And now we will move to our speaker, Dr. Danish. Dr. Danish Talwar is a professor of ophthalmology, PR, and medical consultant. And he is having many publications, and also he is well-known, having many awards. And we are happy to be with us and to listen to him and get an information and benefit from his experience. As I know, he is not an old dad, don't think about like that, but he is having more than 32 years of experience. Thanks, Dr. Danish, for being with us. And he is going to talk today about his topic. It will be angiogenesis in the development of proliferative diabetic retinopathy, impact of intravitreal anti-VEGF treatment. Dr. Danish.
So should I start sharing?
Yeah.
Okay. Okay. Good evening, ladies and gentlemen. The topic for us today is angiogenesis in the development of proliferative diabetic retinopathy, impact on intravitreal anti-VEGF treatment. So we have two aspects: angiogenesis in the development of proliferative diabetic retinopathy, and the second part is the impact of the same on anti-VEGF. This is my disclaimer. Now, what is angiogenesis? We all know angiogenesis is a physiological condition characterized by growth of new blood vessels which originate from pre-existing ones. And basically, this happens when angiogenic growth factors activate the receptors on resident endothelial cells. Once these are activated, the endothelial cells begin to release proteases, which degrade the basement membrane. They allow the endothelial cells to leave the original parental vessel wall, and then they proliferate into the surrounding matrix taking advantage of adhesion molecules called integrins. Now, ultimately, what's going to happen? You have endothelial cell proliferation, then that survives. After its activation, it migrates and forms vessels on the retinal surface as far as proliferative diabetic retinopathy is concerned. But it also causes vascular leakage. So how are these angiogenic growth factors formed in the body? Well, the ideal angiogenic factor, which mediates hypoxia-induced intraocular neovascular response, is vascular endothelial growth factor. And this is both a specific mitogen and a vascular permeability factor. So that means the VEGF can not only account for proliferation of the endothelial cells, but it also increases the vasopermeability of the vessels in the course of proliferative diabetic retinopathy. Now, the high levels of VEGF in vitreous of diabetic patients has been shown in patients with established proliferative diabetic retinopathy, and this is normalized only after laser photocoagulation. Also, prevention of the development of this proliferative stage in a mouse in patients with ischemic retinopathy can be done by blocking VEGF activity. So you block VEGF activity and proliferative changes stop. And finally, we've seen that if you give an intravitreal injection of VEGF, it can cause iris neovascularization in primates. So what exactly is happening? Let's have a look at the broader picture. In diabetes, you have a chronic hyperglycemia, which causes release of superoxide radicals, finally causes advanced glycation end products, release of protein kinase C, and an increased polyol pathway. All these things contribute to basement membrane thickening and closure of capillaries and increased vascular permeability. Now, what's going to happen once you've got a closure of capillaries and you've got a loss of pericytes? You have microvascular alterations like microaneurysms, you have retinal ischemia, and you have an increase in the retinal vasopermeability. And now this contributes to VEGF. Once there's ischemia, you get more VEGF release. So you've started a vicious cycle. DME becomes more because the initial leakage is worsened now. The retinal neovascularization will start because of the VEGF release, and the process of proliferative diabetic retinopathy becomes more and more severe. So what exactly did the VEGF do in PDR? What all do we know from our various studies? We know that in animal models of retinal ischemia, you find VEGF mRNA expression spatially and temporally correlated with retinal neovascularization. So wherever there's neovascularization, you have VEGF mRNA expression. We've seen that inhibition of VEGF, if it occurs, it also inhibits the intraocular neovascularization. We've seen that if you give intraocular injections of VEGF into non-human primate eyes, it can actually cause intraretinal hemorrhages, retinal edema, venous bleeding, microaneurysms. Now, this is very, very important, because what do we talk about when we say that the diabetic retinopathy severity score became better with anti-VEGF? These are the features which become less. So when you talk about, so this can be the basis for the explanation of the diabetic retinopathy regression, which follows multiple anti-VEGF treatments. The other important thing we've seen is that VEGF, intravitreal VEGF levels are elevated in patients with PDR. And bevacizumab given intravitreally causes a regression of both retinal and iris neovascularization. And so what does PRP do? Well, in addition to reducing the oxygen requirement following the destruction of the highly metabolically active outer retinal cells, it also causes an improvement of our retinal oxygenation, because that comes from the choroidal circulation. But most importantly, it causes a decrease in VEGF production due to the destruction of the hypoxic cells, which were releasing VEGF factor. Now, if that's so, then what's our problem? We should be happy, our work is done. But it's not, because there are lots of side effects of PRP, like decreased visual acuity, which may be transient, sometimes more permanent, peripheral vision loss, macular edema may occur for the first time or may worsen following treatment. Occasionally, you can have uveitic effusions, more in patients with nephropathy, and sometimes it can be a fairly painful procedure for the patient. Not only this, many patients need supplemental laser treatments, and sometimes the disease progression may occur despite treatment and require a vitrectomy also. So we got the protocol S to evaluate the efficacy of ranibizumab compared to PRP in proliferative diabetic retinopathy. And in one group, they gave PRP, in the other group, they gave anti-VEGF treatment, ranibizumab. And after 3 months, if there was any neovascularization still present, they gave additional injections at month 4 and 5. And at beginning of month 6, it became as needed injections. Now, if the retinal neovascularization completely resolved or became stable, did not improve or change after 2 consecutive injections, they left the patients alone. But patients who developed progressive retinopathy then got PRP. And what did they find? The group which had anti-VEGF agents had better visual outcomes, less visual field loss, fewer vitrectomies required, and less development of center involving diabetic macular edema. But what was the advantage of the PRP? It was not without advantages. Fewer visits, fewer injections, greater cost effectiveness. But the problem was that more than half the patients in the PRP group needed supplemental laser during the first 2 years of therapy. So it's not just one-time treatment. You may still need to give PRP also again in almost 50% of patients. The other important thing was the chance of PDR worsening in PRP-treated eyes is a little more, 42% versus 34% compared to ranibizumab. The 5-year results were more or less similar, but the differences, the more as if anti-VEGF agents was great and PRP was not, those differences became less over these 5 years. The differences in the fields became less over 5 years. And the visions or visual acuity also more or less became similar. But there is a major problem that came up. And what was that? A major concern was that a large number of patients were lost to follow-up. And we'll talk about the significance of this. only 66%, 2/3 of the patients completed their 5-year visit. And this is very important for what we're going to discuss after this. The other important thing is what we find that if a patient doesn't have diabetic macular edema, yes, 7 injections in the first year, 10 over 2 years, not a small number. But if a patient has diabetic macular edema, the first year was 9 injections mean, and in 2 years, 14 injections. See, one more thing. If the patient had DME with and required and was given PRP, the number of injections became almost half, 5 in the first year, 9 over 2 years. So does PRP decrease the need for anti-VEGF injections in DME? Actually, this is almost looking as if you combine the two, your DME will also require less injections. Your DME may also improve. So the main advantage that we were talking about is in terms of fields. Now, even if you say that the main advantage was in terms of fields and the PRP causes more effect on the peripheral field, there's not much of a negative perception for patients. In fact, 88% of the patients could pass the UK driving test with adequate binocular visual fields. So even though there's not such a big clinical difference, active life difference, the importance is, can we work on this and make it better? Let's see that. Now, after ranibizumab, the Clarity trial used aflibercept to see whether that is better as compared to PRP, and found that new onset center involving macular edema, vitreous hemorrhage, need for vitrectomy, vision loss were all more likely with PRP as compared to aflibercept. So it seems that anti-VEGF agents seem to be doing a good job. But there is a problem. What is the problem? There is a danger of poor treatment adherence to anti-VEGF treatment. What I just discussed, if the patient does not follow up regularly. Now, this was a study where there were 13 eyes of 12 patients who did not come for 12 months for follow-up. And what happened? 9 eyes got vitreous hemorrhage, 5 got neovascular glaucoma, 4 got traction detachment. But worse, almost 50% of patients ended up with a visual acuity of hand movements or worse. A similar response was seen by another study by Obeid et al., where they said iris neovascularization and fractional detachment was much more in patients managed by monotherapy with anti-VEGF treatment. So if you are giving this treatment, beware of this. So maybe the way to go is a combination of anti-VEGF agents with PRP. And there's a study, there are 2 small studies which have shown this. And then there's the Proteus study, which compared PRP plus ranibizumab to PRP alone and showed that, yes, the reduction of neovascularization as well as complete regression was much more common, much more frequent if you combined ranibizumab with PRP rather than did only a PRP alone. Now, this is the important thing. This is not only about regression of neovascularization. What we now see is something completely new, a regression of retinopathy. And the answer to this came from the initial RISE and RIGHT studies, which showed that greater than 2-step decrease in the improvement in the DRSS score, the diabetic retinopathy severity score, occurred in 36% of ranibizumab treated eyes, only 5% of sham treated eyes. In the eyes with the highest risk of progression to proliferative diabetic retinopathy, that is those with severe and very severe non-proliferative diabetic retinopathy, they had the maximum benefit. 75% of them had a greater than 2-step improvement in the DRSS score. A great thing if we can maintain it. The VIVID and VISTA trials showed that aflibercept too can give you a similar response. Up to 48% of patients in the VIVID trial had a greater than 2-step improvement compared to only around 20% of the control eyes, which received PRN treatment subsequently after the first year. Now in Protocol T, we found that it is not just aflibercept, but all the drugs, bevacizumab, aflibercept, ranibizumab, all of them can make a difference in the DRSS score, though bevacizumab was less effective. So we then started looking at, can we use anti-VEGFs not for managing PDR, but for preventing PDR? So if we can prevent the progression to PDR, we are done. And there are two trials going on. One is the Panorama trial, which is just completed, which has been completed, and the DRCR the protocol W, for which I couldn't get the results. I think it's still going on. They haven't got the results yet. So what are we talking about? We are talking about turning this clock back. We are now going to turn the clock back on angiogenic disease process in proliferative diabetic retinopathy. We are not interested in only treating. We are interested in going back and making the patient back to his pre-proliferative stage. Now, I'm sorry, one second. Yeah, so the Panorama study showed that I don't see it published, but I saw this on the study on this .gov site. The data is there. It shows a two-step improvement at week 52 in 65 to 79% of patients on aflibercept, compared to 15% of sham patients. This is great. If we can, if this works out, there is nothing like this. And I think the protocol W will give us more advanced, more detailed answer to this. But there is one important thing to remember when we are assessing this DRSS improvement, the diabetic retinopathy severity score improvement. In a retrospective review, it was found that 61% of patients had a greater than one step improvement in the score. But the non-perfusion didn't go away. On fluorescein angiography, the non-perfused areas remained as they were. So these eyes who have an improvement in the DRSS, the diabetic retinopathy severity score, may still be at high risk of developing proliferative diabetic retinopathy at a later stage. So they still need to be constantly followed up. So I believe that the best way to go is to combine anti-VEGF treatment with PRP in the periphery, leaving the central 2-disc diameter from the arcades so that your fields are untouched. And that would combine, make sure that the peripheral CNP areas disappear, the central area remains protected, and you have a regression of the diabetic retinopathy also. So what I believe is, as of today, if you want to use anti-VEGFs in proliferative diabetic retinopathy, the only thing to remember is if you have raised the neovascularization, because if it's the fibrovascular structures do not go away after anti-VEGF treatment, then complete your laser treatment first and give anti-VEGFs later. And if you got macular edema, you can give steroids during that period. And I think that in the study, in the meeting which we had in Abu Dhabi, this was one of the things which was discussed. If you have flat neovascularization, anti-VEGF agents followed by lasers soon after is probably the way to go. If you have persistent neovascularization after an adequate laser, now manage this patient with VEGF inhibitors and take care of this. Now, what about the role of monotherapy with anti-VEGF agents? Well, I believe you can give monotherapy, but if you've given complete counseling about the need of 14 or more injections in 2 years, with the possibility of even more later, the need for a regular follow-up almost lifelong. You cannot stop following up these patients till you remove the peripheral capillary non-perfusion areas and the possibility of a traction detachment requiring surgery. Giving monotherapy is like catching this tiger by the tail. You've caught it, you can't leave it. You make sure that you stay on the tiger and make sure the tiger doesn't eat you up later on. And of course, if you have a patient who OCT shows a lot of edema in this central macular area, but this is the clinical picture, there is absolutely no role for giving any anti-VEGF treatment in this situation. If you have such severe fibrovascular proliferation, surgery is the way to go, not anti-VEGF agents. Thank you very much, ladies.
Thank you very much, Dr. Danish. An excellent presentations, comprehensive. We didn't move our eyes from your slides. It's an excellent. Thanks a lot. There is many questions, actually. It will be in my mind, I think, Dr. Nadeem. So Dr. Ramai, she can join us if she wants also to have a question. So Dr. Nadeem, I think your time to ask Dr. Danish.
Yeah.
He's waiting for you. He's waiting for you.
No. No, it's a very good presentations, not in terms of what you can do, in terms of understanding the pathophysiology so that you know what and when to intervene with what agents. So this is the most important point. What has caught me in the whole presentation is not the combination treatment, and that is a way to go, of course. And what you say is to give a 50-degree field to the patient with binocularly, we'll never have a problem.
Exactly.
However, what is important, what I found interesting, is can you treat, that's what the study shows, that can you treat with a DRSS score of 50 and less and talk the clock back in a patient, if he's a very stable, probably you may slow the progression, as we know that if you have a mild NPDR and if you have mild NPDR and your sugars are controlled good guy, you have 5% risk of progression to PDR in 5 years. So similarly, that's what the data says. Okay. So similarly, in severe, not very, very severe, or a DRSS score rather, less than 50, if you treat these patients intermittently, can you lengthen the duration of progression? You know, even if the patient needs a treatment, probably later, when his metabolic stability is good, that is a good thing what has poked my brain from that lecture. So the floor is open. I think, Maya, do you have any comment?
Well, more than 100% agree with our distinguished professor. As somebody who started anti-VEGF more than 10 years back, I do remember how impressed we were all when we saw the lack of hemorrhages, the lack of edema in the equatorial and peripheral retina, the ease that we had during laser treatment. However, it was short-lasting. And now in our area in the Middle East, you cannot have a Catholic marriage with the patient, particularly now. He will not come back to you for 3 months, for 4 months. He will be admitted for his cardiac and kidney problems.
Yeah. Yes.
And then he will come with his complication and with his lawyer.
Yes, so that is why I was pointing out this is imperative. See, Maya, what you just told, that's why I told you that the experimental studies show that you give VEGF in eyes, they develop hemorrhages, microaneurysms, bleeding, everything. So if you give anti-VEGF agents, you can reverse this part of it. But this is a reversal of the permeability changes. This does not remove the fact that the basement thickening has already caused capillary non-perfusion. That capillary non-perfusion cannot be removed. So you must do peripheral laser before you let the patient go. You know, we have to make sure our patient sees well. So as Nazimul said, if you can keep a 50-degree field, see, you know, when you go 2 disc diameter beyond the arcade, 15 degrees on either side, 30 degrees, you've given 60-degree field to the patient. 60-degree field uniocularly, and now you have binocular. It's more than 60 degrees.
Functional vision, agree.
Right? It's absolutely functional vision. Now you've given him peripheral laser, all your CNP areas are gone. The reduction in the DRSS will mean this patient will stay stable for years after that. So that's the point. If we combine, we probably have the best chance to give long-term success. And as Maya, as you pointed out, I thought maybe your patients follow up very regularly. But if they don't, then don't ever give them monotherapy with anti-VEGF. That can cause disaster.
You will remember a few years ago, we had a lot of people coming and teaching us that we have to throw our lasers in the rubbish and stop disabling our patients with our laser treatment, you see. However, what I did actually, is to do visual field for my patients with after PRP. And it seems, I repeated that several times because that is the main claim of those people who are advocating monotherapy with anti-VEGF. Now, what happens is that most people with PDR do have significant visual field reduction before any treatment, and that is because of non-perfusion. At the same time, an elegant, scattered, non-confluent, mild laser that is given on time will give actually substantial visual field, not that much of deterioration. And if you monitor these people with time, you will see that it is retained. So we do not disable our patients with our laser.
Absolutely.
Yeah, that's a beautiful study. I mean, that's a beautiful study, and that's very important because that's exactly what the Protocol S has shown, that when you go from 2 years to 5 years, the difference between the anti-VEGF group and the PRP group in terms of the field decreases. The field starts going down in patients who are on anti-VEGF agents, but maintained in those who are on or who had laser. So the difference becomes less over time. So this is exactly the point. And that was a conventional PRP. So if you do the PRP we are talking about, we will give the best results. We will not affect the visual fields.
I think Igor has published using Nevila's laser of targeted PRP. So you do an ultra wide field fluorescent angiography, and then you see the area of non-perfusion, and you just treat the areas of non-perfusion, which you can do with the Nevila's targeted laser. I think all this, but what is important is what you have shown, the physiology. And if that is understood, then everyone will approach the patient rightly and try to give more functional vision, and then without knowing and blasting everything. And lasers have improved a lot. Now that we use multi-spot lasers and we use duration so less, and their pains are less. I think, and it is not confluent. It is the spaces are maintained so well. So probably and the visual field will not be as dense as is used to be before. So I think all these thoughts, when put together, can give a lot of benefit to the patient, but one needs to understand the basic pathophysiology.
One more thing I saw, which which was there. I've been seeing it clinically from the time I was a senior resident, and which I just saw that there was a study on the same. I'd like to point it out. I thought there'll be less time, so I didn't put it into the lecture. Actually, it's been seen that if you use the pattern lasers, they are less effective and sometimes can cause more recurrences. Okay.
Exactly.
Okay. Now the reason for this,
during the American Academy, it came out.
Yeah. So the reason for this, I believe, is that the pattern laser only destroys the outermost layer, but what you need to get an effective PRP is the inner half of the retina. So you need a little more intense laser than what comes in a pattern laser as a routine. So what we need, if Nazimul, if you're going to be using a pattern laser, then increase the intensity. Yeah, you need to calibrate that. You need to decrease the number of spots you do in one sitting. I do my lasers in 4 to 5 sittings. I do one quadrant at a time. I don't want to do it too fast, so that the pain is less. With a pattern laser, with a little more intensity, you could get the right depth of laser burn, so that you don't destroy only the photoreceptor, which is just, I tried this, just visible laser burns versus a grade 3 burn. The grade 3 burns were uniformly more effective in regression of neovascularization as compared to just visible burns. So I think this is a message one should keep in mind. Don't go for the newfangled thing and forget the old thing. Sometimes the old things are doing very well,
Yeah, Mohammed, it's up to you now.
Yeah, we will ask our colleagues if there is anyone have to send his question. He can send question. Anyone, if you want to discuss with us live, he can raise the hand, and we'll give him the chance to be with us to discuss.
Yeah, somebody has raised the hand.
I have some questions. Yeah, Dr. Nazim.
Somebody has raised hand.
Is there any raised hand? I didn't see any raised hand.
You go to the attendees, you will see.
No, raised hand, it should be seen here. Okay, Mr. John, if you can see who is the raised hand, and can you open the mic for him? Send in the chat, please, the name, so we can and open for him. Meanwhile, we get anyone who is raising the hand to participate with us.
Yeah, and we have 5 minutes.
No problem, it's okay. There is a time for us. Don't worry, Dr. Nadim. Dr. Danish, actually, I want just to make like a conclusions from your talk. If we are having a patient proliferative diabetic retinopathy, we are having sure that we can give the anti-VEGF. If there is, so let us divide it in two ways: proliferative diabetic retinopathy with diabetic macular edema, proliferative diabetic retinopathy without diabetic macular edema. So what is the way and the time you are going to give and how you will give? For example, laser when, after how long you will give the anti-VEGF, for how long? So it will be like a practical points so everyone can follow and get the result in a proper way.
See, in diabetic macular edema with proliferative diabetic retinopathy, unless there is raised neovascularization, which is spreading into the vitreous, unless it's really causing traction already, you can give the anti-VEGF agent, and then you can start the laser 1 week later and complete it in the next week or 10 days. So there's no problem. In patients who have no macular edema, both the choices are available. You can do the laser without giving any anti-VEGF, but if you want that you should regress the neovascularization also at the same time, you again give the anti-VEGF agent, but after checking for, again, the tractional component. There should not be too much, there should not be tractional component. It should be just surface neovascularization. Then you can give the anti-VEGF agent, and 1 week later, you start the laser. But in these cases, where there is no maculopathy, the advantage is not very great, because you could do the reverse. You do your PRP first, leave 2 disc diameter from the arcades on all sides, so that you've left a 60-degree field altogether. Complete the PRP, don't go up to the equator, go up to the aura as far as you can. The current generation of lenses will let you go beyond the equator. And after you've completed your PRP, if 8 weeks later you find residual neovascularization, that you treat with anti-VEGF agent. That is the cheapest way of treating it. But if you say no,
how long you will give anti-VEGF? How many anti-VEGFs?
Actually, now if you have done your laser and there is now persistent neovascularization, you will see generally in 2-3 injections, less than 2-3 injections, it will go away.
Okay, so that means only 2 to 3 injections.
You won't need to, but you need to follow them up. Sometimes it can recur again. If it is recurring, then make sure.
If there is any recurrence of the neovascularization of this patient, you will do what they call it filling the lasers, or you will do anti-VEGF alone.
Yes. So if there is a recurrence, if the recurrence is within an area where laser is existing, then I will give anti-VEGF. Okay. If the recurrence is in area where I have not yet done laser, then I will first laser around it. I will surround that area so that if traction occurs, it will not cause a detachment there. And then I will give the anti-VEGF agent maybe 3 weeks later.
Okay. So this is now we finished the proliferative diabetic retinopathy. We have Dr. Muhammad, who is Dr. Muhammad with us. He wants to be with us. Okay, can you open the mic for Dr. Muhammad?
Assalamu alaikum.
Alaikum salam.
Yes, this is Dr. Al-Hazazi from Riyadh.
Dr. Muhammad Al-Hazazi. Hello, marhaba wallah. Welcome.
How are you, Dr. Amri? Thank you for arranging such
nice to hear your voice after a long period of time, Hazazi.
You know, Corona changed everything, so hopefully at least we can see each other in such webinars.
Thank you very much. Yes, Dr. Muhammad, go ahead.
So just only 2 comments. Actually, the first one regarding the laser versus anti-VEGF. It's always hot topic and area of debate and discussion. I believe I don't have the courage actually to leave a patient with only injections, as some of our colleagues mentioned earlier, with just only injections. We are sometimes using both together, the anti-VEGF and laser, and despite the use of both, we're barely able to control the disease. So protocol S, definitely it has to be, the application of these results has to be individualized in each patient. I can't leave a patient with a very aggressive neovascularization over the disc or elsewhere with only anti-VEGF. I do agree totally with that the pattern is not as effective as if you are using a single spot or 4-point. And I keep telling my residents and fellows that 4-point pattern is much better in term, even not only in efficacy, also in term of pain. You can complete the session in one in one session you can complete the whole BRB. However, if you're using 12 or 16, it's extremely painful and patient cannot tolerate, especially young patients. This is one point. The other point is, maybe I missed the first talk about the Iluvien, and probably this is like sharing our experience with from Saudi Arabia. We have used the Iluvien since 2018. It is an excellent tool, and you have just to select this kind of weapon. It has to be in the right hand and for the right patient. Some patients did extremely well, and this is why selection is very important, not to be disappointed, because everyone here believes that there is no 100% medication works for all the patients. Since 2018 until now, some of the patients still completely dry, and they are only with the regular follow-up for the IOP checkup and checking the OCT, structural OCT if there is any changes. Some, they did not do well, minority of patients, and those actually, we discovered that they were not doing well from the beginning. So either they're lately presented to the ophthalmologist, or let's say they were not doing very well in anti-VEGF and even in steroid. So in my humble opinion, if you have patients who did excellent in anti-VEGF, and I have cases that naively injected with or an implant use Iluvien, they did excellent, and they are off medication and excellent vision and completely dry retina for almost now a year or more than a year. This is my opinion. Thank you for yourself and for your panelists.
Thank you, Dr. Muhammad. You can stay with us if there is any comment from Dr. Danish or Dr. Maya, because also maybe I will ask about something to Dr. Okay, we are having Dr. Grakma. She is with us also, John. John, if you can open the mic for another doctor raising hand or not.
Yeah, I already sent for an unmute.
Okay, so we will wait until she opened. Then I will come back to you, Dr. Danish, and to continue let's say the conclusion. Let's me now, yeah. So if we are having a patient, also this maybe I can ask Dr. Muhammad to share his experience. Let us say having a patient, he is non-proliferative diabetic retinopathy. I mean, he is only, as you said, severe non-proliferative diabetic retinopathy, either with macular edema or without macular edema. How do we deal, or how we are dealing with this kind of patient in matter of giving? You know, most of the time we are thinking laser or PRB. It should be only when there is a proliferative diabetic retinopathy. So now we are talking severe or non, let's say moderate to severe non-proliferative diabetic retinopathy, how do you deal with them?
You know, should I answer?
Yeah, please. Yeah, please. This is for you.
You know, in 1991, there was an article from the ETDRS on fluorescein angiographic risk factors for diabetic retinopathy. So everyone looked at the abstract and said, oh, there's nothing in this. But actually, if you go and read that article, you will find it says that patients who have capillary non-perfusion areas in all 4 quadrants, and specifically in the outer and nasal quadrants and upper quadrants, these patients have a 50% chance of going to proliferative diabetic retinopathy within 1 year. So from the time I was a senior resident, after I completed my senior residency, these patients I have been doing a PRP based on this data available publicly. Okay. The change I've made now is that now I've changed the pattern of PRP so that the field doesn't get affected. So in these patients, I will very comfortably leave 2 to 3 disc diameter from the arcades and completely destroy the peripheral CNP areas with the what is the photographic textbook way of doing a PRP. You know, very slowly I will do it and I'll cover all the quadrants, but I will go up to the aura. I will not stop at the equator because, you know, we must know why did we stop at the equator in the ETDRS? We didn't have lenses which used to go beyond that. You know, when we were younger, 30 years back, our lenses could not go beyond the equator. So we made a virtue out of that necessity. It is not that the CNP areas stopped at the equator. They were more beyond the equator. So this is the important thing. Now our lenses can go beyond the equator, up to the aura, go up to the aura. Cover the periphery. You're not destroying any field. Nothing is going to happen negatively to the patient. So in these patients which you're talking about, rather than giving them 8 injections in that year and then still needing to keep them in the follow-up, the capillary non-perfusion cannot go away with anti-VEGF treatment. If you have exudative changes. Now, the second risk factor which is given, again, in the same study, is increased hyperpermeability, vascular leaks in the posterior pole. Again, if they are there in all the 4 quadrants and specifically in the outer temporal and upper and nasal quadrant, the chance of going into proliferative diabetic retinopathy is more than 65%. These are the patients who need to be treated again. So if it's not capillary non-perfusion and it's vascular permeability, ideally, these patients may be better off with anti-VEGF treatment. These are the patients in which anti-VEGF treatment could probably remove the vascular permeability. There is no capillary non-perfusion. You could get a long-term success, but follow-up would still be needed.
Okay, let us, but if we are having severe non-proliferative diabetic retinopathy without macular edema.
Yes, without macular edema, but with severe capillary non-perfusion on fluorescein angiography.
How do you give, did you give with them also this anti-VEGF?
No.
No, only laser.
Just
only
laser. Yes.
Okay. If there is a macular edema, you will do the combination as the previous one.
Yes.
Okay. So this
I showed you protocol S. See, I showed you, Dr. Amri, I showed you that slide of protocol S. If you do PRP along with in macular edema, PRP and anti-VEGF, number of anti-VEGF injections comes down to half.
Yeah, I do remember, but actually I like to stress on a certain point. Yes. With discussion, it will be fixed in our mind.
So this is why if macular edema is there, then injection and laser for the periphery. If no macular edema, only the laser for the periphery.
Okay. Is there any question? Doctora, she did join the other doctors. Grakama, she is there or not? He or she?
Sorry for this, but there's no response.
No response. Okay. Is there any comment, Dr. Muhammad? It's
Yes,
nice to have you here with us.
Thank you very much, Dr. Muhammad. Again, yes, Dr. Danish, he actually raised a very important question, which is the use of fluorescein angiography and actually delineating sometimes subclinical or you cannot appreciate with your exam. So just last week, patient who was examined 3 times, let's say 2 weeks apart from different retina specialists, and myself, I missed the presence of a very tiny MVDs because patient has an early cataract. So I did actually for him fluorescein angiography, and it turned to be that there were really MVDs in both eyes, and this is why it was helpful tool. This is one point for the angiography. The other part is sometimes you are with confidence say that the patient is absolutely involuted based on the clinical picture. However, the patient still, presenting with recurrent vitreous hemorrhage. But I remember that one patient, he behaved the same with the frequent visit to our clinic with either like, very like dispersed vitreous hemorrhage, and providing the patient is one eye so he can notice any subtle changes in his vision. So doing fluorescein angiography, we found there were a small area of capillary dropout temporal to the macula, an area where we'd not actually from the beginning thought that we will apply laser on those areas. But providing that this area is actually non-perfused, so there is actually no harm to the patient to apply a laser. And we did laser. Patient remained stable for a long period after the laser.
Yeah. So I have a comment.
Yes.
Can I make a comment?
Yes, please go ahead. Yeah.
Yeah. So absolutely right. So the technology has advanced so much. None of my diabetic patients, whether it is a mild NPDR, moderate NPDR, on my exam, which is my naked eye exam with my indirect ophthalmoscope or slit lamp microscopy, doesn't go out of the clinic until an ultra-wide field fundus picture is taken. And if I am in doubt, I do an OCT angiography montage just to see whether I need to do. I'm telling you many times these pictures help me to zoom and check. And even the red-free picture helped me to see any surface neovascularization. I'm telling you, if it is small. And if I'm in doubt, I do the OCT angiography over that area and see. If it's in the periphery, I see it, then I go for fluoresceint angiography. Because it is very hard when you see so many patients and you just do an indirect slit lamp and you say, oh, there is nothing. But we may miss those small ones, the points which Dr. Mohammed had just now told. So those small, new vessels. So a photographic examination, I think it helps a lot. Then you take a decision to do. And I feel the ultra-wide field angiography has helped us a lot, especially in diabetic patients. You feel so confident that you have not missed anything, and you know where to target your lasers. I feel our level of confidence has improved a lot than previously when we used to do maximum of 50-degree field or 30-20.
I'd like to add one thing to this. If you don't have an ultra-wide field photography, please do a fluorescein angiography and make the patient look into all the quadrants. Make sure you don't miss anything. But more important, and if you don't have a wide field OCT angiography, so if you don't have the 12 millimeter scans, you could miss peripheral areas of NVE. Please do a fluorescein angiography.
Yeah.
Before you label the patient as, and it will in 5 minutes flat, you will have an answer. You will know exactly how much is the problem in terms of diabetes. Even today, there is nothing like it. It's the fastest way to pick up every lesion.
No, so periphery 100%. Anything beyond 50 degree, You need to
Yeah.
do a fluorescent angiography. There is
Yes.
no doubt about that. It is just that you can use this tool to see on the optic disc and around it
Yes.
fast screening. So yeah, so when you have that, you do a fluorescent angiography cannot be replaced. Dynamic fluorescent angiography cannot be replaced, especially in diabetic retinopathy and peripheral retinal diseases like Yale's retinal disease. So that is 100%. It's a wonderful discussion.
I
Dr.
think we
Amir, can I
already.
add one more
Yeah,
point?
okay,
And
the last
Nazimul, I'm a
comment,
little
please.
old-fashioned, you know.
yes, I think also something relevant to the fluorescent angiography, since everyone is actually in favor of doing such an excellent tool and use on their patients. The use of fluorescent angiography, there is a fear among most of ophthalmologists and even the technicians in some of the hospitals, so they don't allow it in patients with chronic kidney disease or diabetic patients with renal impairments. There is a few studies that we have had a chance to look at, which prove that the fluorescein angiography or the fluorescein dye itself is not harmful, on the kidney. And this is why we conducted a prospective study involving patients with chronic kidney disease, stage 3 or more. And we found that actually those patients, if you measure the GFR before and after the dye, and either the short term or the long term, up to 6 months, there were no effect on kidney function for such patients. The data not yet published. This is unpublished data, but this is just to assure everyone that fluorescein angiography, if there is no allergy to the medication itself, it is relatively, it's an safe dye.
Thank you, Dr. Mohammed Hazazi, and very nice to have you with us and to hear your voice after a long period of time. The last comment from Dr. Amai, if you have any comments.
Very briefly. We keep talking about the patient when he comes to us. It can be pre-proliferative or it can be early neovascular intraretinal background, the retinopathy. To me, it's important to see the progression. If that patient came to me with very mild NPDR 3 months ago and he comes with ischemic changes and peripheral non-perfusion today, I'm not going to read the newspaper for him. Even though it is not a very severe disease, it is rapidly progressing. And it is beyond my reach to manage with his ischemic heart disease and kidney failure. So this rate of progression of the retinopathy to me is as important as the stage of the retinopathy itself. To the technical issues, thank you for your comments on the wide field photography. I strongly believe that the wide field photography needs to move into our diabetic screening clinics. If we pick up such patients early, if we give them treatment, we will not be facing the severe problems that we have with the PDR and poorly responding macular edema. If you remember, dear colleagues, my age, in 1980s, when the national screening started in Iceland, in Reykjavik, it took them 20 years, but in 2000, Professor Stevenson said, nice surgery for PVR and PDR, but we don't have such patients anymore. That is what we need.
Yeah.
Thank you very much, Dr. Banda. Maya and Dr. Danish, thanks a lot for being with us. Dr. Nadeem, Dr. Mohammed Hazazi, thanks for joining us and for your excellent comment and discussions. It was a pleasure to be with you guys, and thank you very much. And we hope to see you, inshallah, in our next webinar. It will be in the 31st of March, and it will be an anterior segment symposium. Till that time, thank you for all of you, and thanks and good
Yeah,
night.
thanks, Mohammed, for
Thank you
considering
very
us.
much. Bye-bye.
Bye.
See you.
Bye.
Bye.
Thank you very
very
much.
much. Okay, good night.
Bye-bye. Good night.
Good night.